lab investigations you want to do in a patient with irritable bowel syndrome. Remember that we said that the physical exam will be normal. Let's get to the laboratory investigations. And you realize that if it comes to laboratory investigations, we are not doing labs because we want to use the labs to diagnose irritable bowel syndrome. We do labs in case of irritable bowel syndrome to rule out other alternating diagnosis. Because usually it's expected that the labs of a patient with irritable bowel syndrome should be normal. Okay, so we will do a complete blood count. If the patient has diarrhea, we will do a fecal calprotectin and fecal lactoferrin test. If the fecal calprotectin tests and fecal lactoferrin test cannot be performed, maybe with where you are, then you want to do a C-reactive protein level. Remember that we are not doing this to diagnose irritable bowel syndrome. We are doing this to rule out other conditions. So if you are cocksure in your exam that this patient has irritable bowel syndrome and they ask you which lab can help confirm it, there is no lab you will do. But if you want to do labs to rule out other alternative diagnoses, then you want to do your complete blood count, you want to do your fecal calprotectin, you want to do your fecal lactoferrin. And if those cannot be done, then you can do a C-reactive protein. You also want to do a stool test for Giardia lamblia. And you want to do serologic tests for celiac disease. And if the patient is around the age where they can develop colorectal cancer, you want to do a fit test as well. And if the patient has, the constipation type of irritable bowel syndrome, then you also want to do an abdominal X-ray to look for fecal impaction. So, again, no lab work will help you diagnose irritable bowel syndrome. You are doing the lab work to rule out other conditions like colorectal cancer, like celiac disease, like Giardia lamblia, like functional constipation. Can somebody summarize what we've done so far? I want somebody to summarize what we've done so far, right from the beginning. What have we done so far? What have we done so far? Can somebody just, remind me of everything we've done so far?
I can do it.
Okay, sure. Please, who is speaking?
So, irritable bowel syndrome, we have
Dr.
to rule out
Sarah.
other
Okay.
things. There will be recurrent,
Mm-hmm.
there will be recurrent abdominal pain,
Mm-hmm.
and it's highly associated fibromyalgia. Other causes can be, what are the other causes like GERD, and it can be related to what are the things? I forgot the list of the things.
Depression, anxiety,
And
fibromyalgia.
anxiety, depression,
Mm-hmm.
and it has the spectrum of, it can be predominant constipation, predominant diarrhea, it can be a mixed picture.
Mm-hmm.
And there is no scene of, we cannot say it's a predominant constipation with heartburn. That would be an incorrect answer.
Mm-hmm.
And for laboratory, we have to see their abdominal examination will always be normal. But if the
Mm-hmm.
patient is suffering from constipation, we have to do digital rectal exam
Mm-hmm.
to rule other causes of uh, abdominal pain.
Mm-hmm.
And we have to do the calprotectin, fecal calprotectin levels and fecal lactoferrin levels.
Mm-hmm.
And we have to rule out previous, if the patient is suffering from Giardia lamblia, or if the patient is having celiac disease, or we have to rule them out. And we have to do the age appropriate colorectal screening also. And if the constipation is there, we have to do abdominal radiograph to assess for stool accumulation and severity. And we also have to do 3D abdominal radiologies, and we have to do ultrasound also. If we are thinking as a differential, if we saying it's IBS with abdominal distension or ascites, we have to do three ways of X-ray and ultrasound. And we have to do, for ascites, we have to do serum albumin to ascitic ratio, and that's another thing. Then we have to see if the ascites, we have to do exudate or transudate and so on, paracentesis.
Well, okay, good.